Right, so we're going to try and cover the neurological side of celiac disease and gluten sensitivity. Next. Oh. Yeah, that's what I tried to do. Here we are. So I thought we'll start by clarifying definition. So Mike Marsh used the term gluten sensitivity back in 1995 to talk about the state of heightened neurological responsiveness to ingested gluten in people who have the genetic susceptibility. And then, of course, things change over time in terms of what people mean about gluten sensitivity and celiac disease. In 2011, a group of us got together in London and used the term gluten-related disorders as a group of diseases triggered by gluten, which of course includes celiac disease, dermatitis herpetiformis, gluten allergy, and the neurological manifestations. And you heard this morning by Knut about the concept of non-celiac gluten sensitivity. When we use the term in neurology, we mean something different. These are patients who are all positive for gluten antibodies. These are not just patients that come and say that they get better when they go on a gluten-free diet. So it's a slightly different cohort we're talking about. So how did it start? Well, back in '94, we started screening patients with neurological problems for gluten sensitivity. And we found that a very large number of them had positive anti-gluten antibodies. In fact, the prevalence of celiac disease in that cohort was at least 16%, which is, as you understand, much more than in the healthy population. And that kind of triggered our interest in the field, and we went on to set up a gluten neurology clinic, which I've been running since then. And to match the 50th anniversary of Coeliac UK, we matched the 1,000 patients that I've seen with gluten and neurology problems. And we now know the kind of things we're looking for. So ataxia tops the list. Neuropathy is the second commonest. Encephalopathy, and I will explain what that means. And I'll mention a bit about myoclonic ataxia as well, because I think it's quite interesting. What I want you to notice here is that the prevalence of enteropathy in this group interestingly varies. So only 50% of the ataxia will have celiac disease, but all of these people are positive for gluten antibodies. The myoclonic ataxia is also very interesting because there's a strong association with refractory celiac disease. So gluten ataxia is the commonest cause of late onset ataxia. It's the red chunk here. It's about 25% of all the ataxias after the genetic ones. So it's very common. And it's quite a while now since we showed that patients with gluten ataxia improve when they go on the gluten-free diet. And the concept of celiac disease, non-celiac gluten sensitivity might be new to the gastroenterologist, but is not new to the neurologist, because even then we were demonstrating that patients who didn't have enteropathy were neurologically improving. And there is one difference, however, which is that the bowel has the capacity for regenerating, so you can go on a gluten-free diet and go back to normal mucosa or expose yourself to gluten and go this way. But usually you can recover from that. I'm afraid the same is not true from the neurological perspective. So once this is a section of the cerebellum, these are the large Purkinje cells, very important for cerebellar functioning. This is a patient with gluten ataxia, and you just about see one Purkinje cell remaining here. So you're not going to go back once you reach that stage. And this is just showing you a scan of somebody with ataxia. This is at presentation. You see the cerebellum looks a healthy size, and this is 15 months later, and you can already see that the cerebellum is atrophied. Okay, so moving on to gluten neuropathy. So this is damage to the nerve endings. It accounts for about 26% of all neuropathies, and a study from Finland showed that if you actually do neurophysiological testing in a group of patients with established celiac disease, 21% actually have a neuropathy. And the big epidemiological work from Sweden by Ludvigsson and his colleagues showed that there's an association between neuropathy and having celiac disease. Again, we did a study a while back that we showed that there was evidence of improvement in neuropathy with a peripheral neuropathy because you have more propensity for regeneration of the peripheral nerves. There's probably more likely to have some impact in those cases. And more recently, Dr. Ziz, who's a colleague of mine, now appointed a consultant in Sheffield, was able to show that, firstly, that pain is very prevalent in patients with gluten neuropathy. This is neuropathic pain. But also that those patients who were strict on gluten-free diet with elimination of the antibodies, there was associated with significant reduction of the odds for neuropathic pain. What do we mean by gluten encephalopathy? It's a rather loose term, but what it means is that these patients have, sometimes they use the term foggy brain, but if you actually test them, they do have cognitive deficits. They often have episodic severe and sometimes intractable headaches. And it's interesting because there have been a few reports recently where people actually go on to, some of them develop acute psychosis. Sometimes they had white matter abnormalities on the brain scan. And of course, when they go on a gluten-free diet, all of these things tend to improve. This is what the scan can look like. So you have these sort of white patches of vascular, or whatever other term you want to use. But this is a lady who never went onto the diet, so this is 2 years down the line. And you can see that it's much more extensive. And of course, the question is whether or not this may be a contributory factor to developing what we call vascular dementia. And interestingly, again, big epidemiological studies from Sweden have shown that although patients with celiac disease are not at an increased risk of dementia overall, if you look at the subgroup analysis, it suggests that they may be at increased risk of vascular dementia. So these patients may have an impact on their cognition later on in life. So a bit about the diagnosis and monitoring, which I think would be very interesting to you. So as we said, if you only use the endomycin transglutaminase 2 antibodies, which are specific to the presence of an enteropathy, you're going to miss 50% of the patients who present with neurological problem. Now, we have been using anti-gluten antibodies right from the start, and all our data in terms of improvement are based on these patients, and therefore we are still using anti-gluten antibodies in addition to endomycin and transglutaminase. And I'll say a bit more about TG6 later. In terms of the monitoring, we use a technique called MR spectroscopy. So this is in addition to just having an ordinary MRI scan. It doesn't take that much longer to do. Just very briefly, you have these 3 peaks. The NAA reflects how well your cells are functioning in that voxel over your brain, in this case the cerebellum. Creatine doesn't change in health and disease. So if you use the ratio of NAA to creatine, it gives you an indication as to the functionality within the balance center. Normally it should be well above 1, as you can see here. But what you see in patients with ataxia and gluten ataxia is that this is reduced. And when you put them on a gluten-free diet, you can improve this, which implies that the metabolic activity within this area, the cerebellum, is improving. And this correlates well with the clinical findings. So we now have data in a lot of patients, and you can see that those who go on a diet and they get rid of the antibodies because they're very strict, this goes up. If you don't go on the diet, this gets worse. And if you go on the diet but your antibodies are still positive, you are somewhere in the middle, but overall you are still heading down. And this is a summation of that. So if you have, if you are on a gluten-free diet, improve, no diet, worse, partial diet, somewhere in between. Now, this is the same, similar graph, but this time excluding all the patients with enteropathy. So you have identical results whether you do or do not have enteropathy. So I thought I'll use a few clinical vignettes just to highlight how we go about managing such patients and what is the kind of referral that we tend to get. So a patient with known celiac disease on gluten-free diet that develops ataxia. That's a fairly classic referral. So it comes to us and we do endomysium, negative, transglutaminase 2, negative, Gluten antibodies, positive. So all you need to do with this patient is to get somebody like Nick Trott, I think Nick might be around, who is an expert dietitian, have a chat with the patient, go over the diet in detail, and then this is what you get. So normalization of the gluten antibodies and clinical improvement. What about a patient presenting with ataxia, diagnosed with gluten ataxia by us, who seems to be stable on a gluten-free diet, but suddenly his ataxia gets worse? Blood test, suddenly gluten is positive again. So there's something to do with the diet. So again, dietary review will enable those levels of glutens to go down and the patient to improve. And indeed, this is the case with this particular example. What about the patient who is extremely disabled by their ataxia and hence difficult to demonstrate any clinical improvement? Well, that's a difficult one because not only the patient is disabled by being wheelchair bound, but you're now telling them that they need to go onto a strict gluten-free diet. And you know that they're not going to be able to start walking again because they've already got significant atrophy of the cerebellum. And if you look at the NAA here, it's as low as it possibly gets. So all you can achieve is stabilization. And sometimes doing the scan and showing that improvement on the scan is a good motivation for the patient to continue the gluten-free diet. Patient with newly diagnosed classical celiac disease referred by gastroenterologist, usually Dave Sanders, well-trained in neurology again, because of complaining of poor balance. His scan here, for a youngster, this should be up there, not there. So she's already got abnormal cerebellar functioning, which reflects how she had difficulty with tandem walking. Patient with no enteropathy, therefore negative for TG2 and EMA, presenting with ataxia is positive for anti-gluten antibodies only. So it's unlikely that they're going to have celiac disease, but they clearly are gluten sensitive. So if at your center you are using endomysium transglutaminase, this patient would be sent home and say, well, haven't found anything gluten related. And yet these patients equally benefit from a gluten-free diet. There you are. So this improves and the patient is also much better on the diet. And finally, and even more difficult, is a patient with no enteropathy, therefore negative for TG2 and EMA, presenting with ataxia whose level of anti-gluten antibodies is below the cutoff for what the assay uses for celiac disease, but still significant for neurological manifestations. So in 2015, the immunology lab changed our gluten assay without telling us. It took me about 2 weeks to realize that, because we have patients who've been looking after for years, some of which are not on the diet, and therefore we know what to expect. So I went to meet them, and I persuaded them to give us the titer rather than just giving us positive or negative. And using that information over hundreds of patients, I was able to show that patients whose gluten antibody is above 3 is significant, but the cutoff is above 7. And to prove this, here is the data from patients whose gluten antibodies are below 7 but above 3, and you get identical picture. Those who strict on the diet improve, partial diet get a bit worse, no diet continue to deteriorate. So you can see why it's so important to micromanage these patients to be able to have an impact on their neurological problem. So why do we sometimes see poor response? Well, poor adherence to a gluten-free diet is by far the commonest. The patient may already be disabled by severe ataxia. We talked about considering refractory celiac disease. And sometimes you need to consider an alternative diagnosis. If the patient is not responding how you want them to respond and they're very strict with the diet, they may have another cause for their ataxia. So you need to always be open to that possibility. Right, moving on to some important questions. The first question is, are we dealing with two different cohorts of patients, those who present with gastro symptoms, the classic CD, and those who present with neuro symptoms? And is there much overlap between the two? So to answer this question, with funding from Coeliac UK, we basically examined 100 newly diagnosed celiac patients who Dave diagnosed in his clinic. We examined them and we did brain imaging. And if you ask the patient about headache, balance problems, sensory symptoms, 61% complain of those things. On clinical examination, a third almost had evidence of gait instability, like I showed you with that young girl. 11% had nystagmus, which is a sign of cerebellar dysfunction, and 5% had sensory signs. What is even more interesting is that 46% had abnormal scan. This is a diagnosis of celiac disease, patients with a classic celiac disease. And 19% had abnormal white matter lesions over and above what you might expect for age, as compared to 3% in the healthy population. So patients with a classic presentation of celiac disease frequently have neurological symptoms and signs, but remain unreported by patients and undetected by doctors, primarily because no link is made between the two. Are there any clinical and serological differences between patients with celiac disease presenting with neurological manifestations to me versus those who present to the gastroenterologist? Well, yeah, because firstly, the age at diagnosis is different. The classic celiac disease is about 44. The ataxia patients is 53. And those who present with ataxia, as you might expect, are more severely affected. So what this means is that if you are lucky enough to have your bowel symptoms and therefore get diagnosed with celiac disease, you are less likely to go on and develop neurological problems later on. Third question, are there any clinical and serological differences between patients presenting with neurological manifestations who have enteropathy versus those who don't? And the simple answer is no. And we've looked at these two groups, and they have identical presentations, and they have identical severity of their neurological problem. So you cannot tell. You cannot say that, oh, because you've got enteropathy, you are more likely to be more severely affected. So the conclusion is that there are no clinical differences between patients with enteropathy and those with non-enteropathy in terms of the type and severity of the neurological dysfunction. But the most important thing is that they equally respond to a gluten-free diet. The final question is why such diverse manifestations? And we need to go to transglutaminases. You heard a bit about them this morning. Aside of TG2, which is obviously the autoantigen in celiac disease, TG3, as you heard earlier on, is the autoantigen in dermatitis impediformis. And we have found with the work of Daniel Eschliman in Cardiff that TG6 is the autoantigen in neurological manifestations. The three transglutaminases have 65% homology. They share the same genetic background. They can deamidate gluten, and the antibody titer reduces when you go on to a gluten-free diet. And we were able to show that TG2 reacts with brain vessels but no neural tissue, whereas TG6 reacts with brain vessels but also reacts with neural tissue. And I haven't shown you all the data, but TG6 antibodies are much more prevalent in patients with celiac disease who present with neurological problems. TG6 is primarily expressed in brain, TG3 in epidermis, Whereas TG2 is more widely expressed, so you find it in brain vessels, you find it in the gut, in a lot of other places. But we have shown that transglutaminase antibodies and gliadin antibodies do cross-react with neural tissue and can induce ataxia in mice, which is why it's so important to get rid of the antibodies by being very, very strict with the diet. So the final conclusions are that neurological manifestations are common, that early diagnosis and treatment avoids permanent neurological disability. Diagnosis and monitoring for the neurologic cases is more complex, and that more research is needed to clarify any additional manifestations. For example, does this lead to some vascular dementia, as well as trying to clarify further the pathophysiology. So I wanted to thank my friends and collaborators. Thanks for listening.
So I think we've got time for just a couple of quick questions, if anybody has any.
Quick, two questions really. Cerebral calcification and epilepsy in children, certainly a well-known association. Do you see that in your adult patients?
No, I think I've come across 2 patients of all the 1,000. I think it's rare in the UK, but it's also a disease that I think it's more found more in children with epilepsy. There's a poster by Tom on epilepsy in celiac disease today.
So that's my second question. Overt epilepsy and celiac disease. You're obviously dealing with gluten-related neurology. You've not mentioned in your talk about epilepsy.
Yeah, I didn't have time, and because there's a poster. No, I think, which is why Dagis and Tom did the systematic review, because there are papers showing, and as the poster basically says that is double the prevalence. The difficulty is that a lot of these papers group epilepsy as one condition, and we know it's a heterogeneous condition. But I think the subgroup of patients who have focal epilepsy, like the occipital calcifications, there's probably a good story there. Because in the occipital calcification cases, when they go on a gluten-free diet, their epilepsy is much, much easier to control. Sometimes they come off the anti-epileptic medication. So it's an interesting area.
Thank you.
Wonderful talk, Marios. What is the titer of anti-gliadin antibody in these patients? It's very high. Like
which antibody?
Anti-gliadin antibody.
Gliadin. No, the gliadin antibody level is usually more at the low end by comparison to, say, the classic celiac cases.
For example, in celiac disease, we say 10-fold, 8-fold,
Yeah.
7-folds, but they're not that high.
No.
In fact, we did the same study in about 250 patients with ataxia, and we found that about 20% have an AGA positive, but again,
20%.
Yes, but titer is low. It's not more than 3-fold.
Which is what
Only
we
one
found.
patient had about 120, almost 15-fold high.
Mm-hmm.
My second question was, are they IgG or IgA or both?
Either. I tried my best to see if there's any clue to the IgA, IgG story, and I'm afraid there isn't. So it can be one or the other, and
Or both.
Or both.
And my last question is, do you find overlap, genetic and AGA positive?
Genetic?
So those who have a family history and they have a gene for hereditary ataxia and SCAA 1, 2, 12, 4 or whatever.
Much less common. The prevalence in genetically characterized ataxias is more or less the same as the healthy population in our cohort.
Okay.
Thank you.